thanks for coming tonight. Tonight we have Dr. Eric Jackson. He's pediatric neurosurgeon at Johns Hopkins University. I think you also see adults, is that correct? Yes. And we've worked with Dr. Jackson for a while. He's been on our C board. We worked on some guidelines, which I believe you're going to touch on in your conversation tonight. And actually, Dr. Jackson is one of the sites in the Chiari Surgical Success Scale, which Alina's here too. She's involved. So we have a lot of work that it's going on with Johns Hopkins specifically and Dr. Jackson also specifically. So thank you very much for speaking tonight, and I will let you go ahead and get started.
All right, thank you. All right, so I know that there's been some talks about the guidelines on these webinars and meetings, but I thought I would kind of start with that and then say, okay, now we have this, what's next? Always have to start talks with disclosures. My research here for Chiari is funded by a donation from Dr. Wild. I am a consultant for Integra, although it's not related to Chiari. And then finally, I think the most important thing for this talk, where there will be what we consider level 4 evidence, which is, quote, expert opinion. Chiari is a diagnosis with a significant surgeon bias. And so some of what I'm going to say is going to be how I approach things, and you may get different opinions from other people. So, recently the CNS guidelines for patients with Chiari I malformation was released. There are 3 chapters, one on imaging, one on symptoms and diagnosis, and another on treatment. And they were published in Neurosurgery in October of 2023. And I'm going to go through them quickly. The first chapter was on diagnosis. The questions, the first question was, in patients with Chiari, is complete imaging needed to evaluate for other pathologies such as brain tumors, hydrocephalus, syrinx, or tethered cord? The recommendation is patients diagnosed only with a brain or cervical spine MRI. Further imaging may be helpful to evaluate for clinically relevant pathology. And something that's going to come up a lot as I review the guidelines, strength of recommendation is grade C, and that's based on level 3 evidence, which is not strong evidence. Question 1-2, are advanced imaging modalities such as Cine MRI helpful? And this is something that we often get asked in clinic, and the recommendation is in patients with Chiari I that advanced imaging such as Cine MRI may or may not be helpful. It may or may not help predict who may benefit. Again, part of the problem here is that there's not very good evidence. Most of it's retrospective, and so it's not a very strong recommendation. The third question in the chapter, should flexion extension imaging be routinely performed to evaluate for instability? And are other measurements looking for craniocervical instability helpful? What was found in the recommendation from this chapter was measurements like things like the clivoaxial angle, the PBC2, the C2 SVA may help predict future instability and need for future fusion, but aren't something that necessarily is used kind of preoperatively. Again, grade C and level 3 evidence. And there is not evidence to support the use of flexion extension imaging, which means there's not actually good literature either way. So the summary of chapter 1 is that we have class 3 evidence that imaging of the entire central nervous system may be helpful. Advanced imaging may or may not be helpful, and current craniocervical metrics may help predict the need for fusion in the future. So we have 3 grade C recommendations based on level 3 evidence, 1 insufficient recommendation. So what we get from this is there is significant need for additional high quality evidence for the workup of Chiari I. Chapter 2 was looking at symptoms. And I think one of the questions that we think about the most in clinic is this first question: what symptoms are most likely to improve after surgery? And reviewing the literature, that it was felt that Chiari decompression can be used for symptomatic patients to help improve pain associated with strain-induced headaches. Other symptoms are more variable. And what that means is when we look at all the literature, a lot of these other symptoms that people attribute to Chiari, one paper says they get better, one paper says it doesn't change, another paper says it gets worse. And so there's really not evidence to support any of these things, whereas the strain-induced headaches were really the one thing that all the papers were fairly, I wouldn't say all, but fairly consistently we saw improvement in changes. Again, though, it's a grade C recommendation, level 3 evidence. What about some of the other questions we get asked in clinic? Asymptomatic patient without syrinx, do you do a prophylactic surgery to prevent the need? And what's the chance of developing symptoms in the future? The recommendation based on the literature out there is that you should not do prophylactic surgery, as there's only really a small percentage of patients who develop new symptoms or get worse. So you should follow patients and treat them if there's worsening, but don't need to prophylactically treat an asymptomatic patient with no syrinx. Again, grade C recommendation based on level 3 evidence. I said there would be a pattern, and it keeps coming up. What about asymptomatic patients without syrinx? Should they have activity restrictions? And again, reviewing the literature with level 3 evidence, there should not be activity restrictions, and the key word here is asymptomatic patients without syrinx. I think for symptomatic patients, there is more concern about harm, but in asymptomatic patients, there's no evidence of preventing harm by restricting patients. Obviously, you may want to have a discussion about what the risks are, as theoretically the risk probably is higher, but it may be so uncommon that it's not worth avoiding things altogether. What about sleep or swallow studies in patients? As we know, it's a symptom that patients with Chiari can have. And there really wasn't enough evidence to support the routine use of these studies, so it was an insufficient recommendation, so there wasn't one actually made. And then finally, another question that comes up commonly is, should siblings or first-degree relatives of patients with Chiari get screened? And the literature primarily shows that there can be a familial component to Chiari, although we believe most patients we see are not relatives. But as we just talked about, we don't recommend surgery for asymptomatic patients. If you have an asymptomatic sibling, there's not evidence to support routinely screening them. Now, again, in my personal practice, my threshold for getting a scan in a sibling or first-degree relative may be a little bit lower. So if they have symptoms, I may get a scan quicker than what someone may if they didn't have that. So Chapter 2, 4 grade C recommendations, level 3 evidence, 1 insufficient recommendation. So take home, again, significant need for additional high-quality evidence for symptoms of Chiari 1 other than strain-induced headache. Finally, Chapter 3, I think the most controversial chapter, surgery. And so questions here relate to more what type of surgery and what are you doing during surgery. So in patients with Chiari 1, what type of surgery most often improves symptoms? Posterior facet decompression, PFD, which I'll typically refer to in my talk as a bone-only decompression, or PFDD, posterior facet decompression with duroplasty. The recommendation in patients with symptomatic Chiari 1, either PFD or PFDD may be utilized as a first-line treatment. Again, class 3 evidence, grade C strength. And effectively, it's just saying that there's evidence that both work, and so they can be done. And there may be subsets, but even within the subsets, there's not consistent data across papers. Another question is tonsillar reduction beneficial? Again, some evidence says it is, some evidence says it's not, so may perform it with grade C recommendation, class 3 evidence. And I'll talk a little bit more about this and some other things in terms of my own feelings as we go on. What about intraoperative monitoring? Is there a role for it? And again, some people use it for every case. Some people don't use it at all. Some people use it selectively. Looking at the literature, the feeling was it may be used, but wasn't clear that it necessarily added something to all cases, so there was not a strong recommendation made. And then finally, the one class 2 grade B recommendation was in a patient with Chiari and syrinx, how long should you wait to see if it gets better before performing additional surgery? And the recommendation was 6 to 12 months. And there is some literature, especially that with bone-only decompression, it may take longer for them to get better. But I think the idea here is if you're seeing no improvement by 12 months, it's probably reasonable to think about doing something else if you believe there is a symptomatic syrinx or a syrinx that needs treatment. And then finally, in patients who have been treated, is long-term follow-up needed? And I think that the recommendations, again, looking at the papers, there's different evidence, but ultimately it was felt that you can monitor for symptom or imaging changes. Again, I think we all have our own practices. My personal practice is without a syrinx. I tend to follow for about a year. For patients with a syrinx, I tend to follow longer because I have seen late recurrence of syrinx. Again, some people will just say, call me if there's a problem, and most of the time patients would have symptoms. So again, it's a good question, but we don't have a great answer based on the lack of good evidence. So we have 1 grade B, 4 grade C recommendations. And so again, there's a need for additional high quality evidence for determining optimal surgery and follow-up for Chiari 1. So what's the future here? Our review of the literature for these guidelines really highlights the lack of class 1 and class 2, although there was the one question with class 2 evidence. So really the guidelines don't make any real strong recommendations. What this does is it highlights the need for multi-center prospective data collection regarding symptoms, natural history, as well as surgery. It's the multi-center prospective studies that give us level 2, potentially even level 1, depending on randomization, evidence to make better recommendations. Speaking of level 1, the clinical trial of PFD versus PFTD will provide additional data and has been submitted and hopefully should be accepted and published soon. But we really need more studies to clarify the optimal management. And I think it's important to include patient-centered studies, which include patient-reported outcomes, to help us decide. Because it's one thing for me to say somebody's doing well, it's another thing for the patient to think that. Yes?
So could you go through, because I know you know what level 1, 2, 3 evidence is and strength of papers. Can you go through what would make level 1 evidence, what would make level 2 evidence, and then how do you determine the strength?
So the simplest way to think about it is level 1 tends to be randomized controlled trials. There are other kind of things that can fit into that, but for the most part, it's a trial that is prospective, that patients are enrolling in ahead of time, and somebody other than the doctor is deciding what treatment they get, because that then removes that surgeon's bias in terms of selecting it. Level 2 can include some poorly designed randomized studies, but it also includes prospective groups of patients that are followed over time, where you're asking specific questions and doing it over time. Level 3 tends to be more retrospective or case control, case history. Level 4, and it's one of those where if there's actually different criteria, if you look at different websites. Level 4 we tend to think of as more expert opinion. So a group of people get together, or somebody says, this is what I think. The ABC are based on, for the strength of recommendation, are based on the level of evidence. So if you have good level 1 evidence, then you can make a strong recommendation, which is an A. Because most of the evidence here was grade level 3, it was grade C recommendations. So which are not very strong, and so it's one of those that effectively, why the wording in the guidelines was as such, may or may not, because there's not good enough evidence to tell you should do it one way or the other. So effectively, that kind of leads into the slide. So now what?
I have one more question. So you created guidelines. You published them in the Journal of Neurosurgery. Who reads them, and why does the group feel like guidelines are important?
So in general, the Congress of Neurological Surgeons has a large guidelines initiative where they're publishing guidelines throughout neurosurgery, and then there's actually a joint group between the Congress and the American Association of Neurological Surgeons that will look at and approve guidelines, both written by the Congress and by organizations outside of neurosurgery. And the idea is it's a systematic review of the literature to try to provide evidence-based medicine recommendations for how to treat things. And so the idea of putting these together is to answer or is to look at questions that come up in clinical practice and answer them in a way that's useful for clinicians. So obviously, anybody can read these guidelines, but I think for the most part, it's intended for physicians. But I can say I recently had a patient who was asking about screening family members, and so I printed it up and gave it to them, and so they can read as much of it that they want to, but just that there is this information out there. And I think at the end of the day, even though we couldn't make strong recommendations, I think what it does do is it gives a good state of the literature and a good review of what's out there to say, okay, what can we do better and what do we need to look at more? And that's effectively what this slide is saying, is that now what we have these guidelines, we have as many questions as answered. So do these guidelines change my practice? No. I think they're helpful in that I can give a patient a paper, or a family member a paper, but I think it doesn't really get to the point of giving me an answer of how to best treat my patients, and so we need to do something more. And I was asked recently to give a talk on Chiari I Malformation, what's the best practice? And I think the way I broke this down, and also thinking about guidelines and what do we want, for me, I think about Chiari as the right operation for the right patient. So you need to have good patient selection, and you need to have the right procedure or not procedure for them. So the first question there is whether or not to operate. And sometimes the right operation is no operation. I would say in general, based on the literature, the majority of the time for patients with Chiari, or a large percentage, the right operation is no operation. Once you've decided that you are going to operate, then there's a question of whether you open the dura, whether you reduce the tonsils. In patients that have a syrinx, do you place a stent? And then finally, one thing that has been coming up a lot more recently is whether to fuse. And that's something that's not really as much part of my practice, so I'm not going to discuss it. So the goal, the right operation for the right patient, and it really is prospective data that we want to help guide us. And there's a few things to think about, and I'll give a couple of case examples. So the idea is we need to treat the patient's primary problem. So if they have a primary Chiari, then surgery for Chiari is the right thing to do. But what if they have a secondary Chiari? And an example of this, a patient I took care of a few years ago, a young, healthy, active female who had headaches that had worsened for about 6 months. They were clearly worse with straining. She said she stopped doing deadlifts because it caused her to be so symptomatic. She also woke up with a morning headache, which we tend to think of more as a pressure-related headache, not a Chiari headache. She was noted to have a Chiari on imaging, as well as slightly increased ventricles. This is the scan that her primary had ordered that she came to me with. And I looked at it, and obviously she has significant Chiari malformation with pointed tonsils here, but the ventricles are a little bit large, and I was kind of wondering about the anatomy at the aqueduct. So a couple of things I wanted to do. I sent her for an eye exam. An ophthalmology diagnosed her with papilledema, indicating she had elevated intracranial pressure. And when I got this fine cut MRI, we could see that she has aqueductal stenosis. So she effectively has hydrocephalus. And if I just do a Chiari decompression here, there's a good chance she's going to have a complication like a CSF leak or something, or she may get better and then she just gets worse again because we haven't fixed the primary problem. So in this patient, instead of doing a Chiari decompression, I did an endoscopic third ventriculostomy. And what we can see after that is the anatomy of the ventricles got better. At the same time, the Chiari got better. There's more space there. So her problem was not Chiari, it was hydrocephalus. And fixing the hydrocephalus makes the Chiari better. She's now a couple years out. We've never treated the Chiari, and she's back to being active and doing deadlifts and doesn't have any symptoms with it. So high pressure can be a problem. Then there's this patient, another patient who presented with classic tussive headaches. I strain, I get terrible headaches. And this is her imaging when she came to see me. She has a pretty significant Chiari, pointed tonsils. Interestingly, she'd had an MRI 4 years before and did not have a Chiari malformation. She is not a pediatric patient, is fully grown, so this should not change at this point. So this makes me worry about secondary Chiari again. We got an MRI with contrast, and she has diffuse enhancement of her dura, which suggests she has low pressure and probably a CSF leak somewhere. So send her to my interventional radiology colleagues. She had one directed blood patch, got better, symptoms came back, got another, and you can see here, this is her imaging after that. The Chiari's improved, and the leptomeningeal enhancement is better, and her symptoms got better. So again, the treatment for her wasn't fixing the Chiari, it was fixing the problem, which was low pressure. So with secondary Chiari, we really have to think about the etiology because we have to treat the source, not the Chiari. And so I think there's two things with it. One, it's if you're going to do a Chiari decompression, always thinking about, am I missing something here? Is there a problem? And then, use that in your decision making. Sometimes we don't know. And I have patients where by history I'm wondering about low pressure, but I can't find any evidence of it. Same thing with high pressure. And so do you just ultimately do the Chiari decompression, or do you do more of a workup? So what can we learn about this by prospective data? We can learn the incidence. So if we're following all the patients who are coming in with Chiari, we can figure out how many of them actually have this problem and have better statistics of how much should we be thinking about it versus thinking about it in everyone and never treating a Chiari that needs to be treated. And then also, what's the best way to diagnose this? Like I said, for high pressure, sometimes we'll think about papilledema. For low pressure, it's great if we see enhancement on an MRI or if they had an old MRI, but what about the patients who didn't have an old MRI and didn't have enhancement? Are we having to do ICP monitors? And is it something where at a certain point you decide, I'm just going to treat it, and if I don't get better, do I go down that way? So those are things that I think data can help us. Going back to this question, right operation for the right patient. So that's whether to operate. What about whether to open the dura? So I think there is a lot of discussion and literature on bone-only versus duroplasty. I'll highlight some of that and then think about a couple of examples of how I think about it in the sense of we can have as much literature that we have now, but a lot of it is percentages in the sense of, okay, if you have a bone-only, this percentage get better, a duroplasty, this percentage. Those percentages are things we can talk about with a patient, but it's not a cut and dry yes or no, and you have to use that information in terms of counseling. So here are just a few examples of papers that are out of Park Reeves that look at patients with syrinx. And one of the papers, for instance, shows that duroplasty was independently associated with syrinx improvement. But getting to the point I just made, syrinx can't improve with either. So you can get a bone-only decompression and your syrinx can get better. And so not all patients with a syrinx necessarily need a duroplasty. Now, we know, though, that it is more likely to improve with opening the dura. And so a lot of times we will counsel patients that, based on the literature out there, and I think there are some papers that say otherwise, but I think the best literature suggests that if you do a duroplasty, you're more likely to have a syrinx improve. But it doesn't mean that all patients need that. The other thing that I think is important, and goes back to that guidelines question about how long do you wait, we do know that syrinx does take longer to get better if you do a bone only. So you may want to wait longer if it's just based on syrinx. Another thing that I think is an important finding in this paper relates to patients who come in with a lot of symptoms, and we're not sure whether or not they're related to Chiari. In this paper, they found that if the syrinx got better, they thought the symptoms that were likely Chiari related also got better. And so what that says to me is the syrinx can be a marker for patients. So if you treat the Chiari and the syrinx gets better, the symptoms that got better are going to be the most likely to be the ones related to Chiari. If they have other symptoms that maybe are on some internet lists that are related to Chiari but don't improve, then those may be less likely to be related. Now, obviously, if the syrinx doesn't get better, then all bets are off and everything's still good. But I think it's an important thing to have something that's objective that we can use. And I think in this case, that's an important point in this study. Now, what about complications? So it's known that a lot of literature says that complications are higher if you open the dura. There may be a study published soon that doesn't necessarily indicate that, but I think for the most part we tend to think that there's more risk when you open the dura. So how do I decide whether or not to open the dura? And I think this slide is kind of the keep it simple, stupid philosophy. But for bone only, I think people who have anatomy that's good for bone only, or a reason that is bad for duroplasty. Same thing. If you're thinking about duroplasty, is their anatomy bad for bone only? Do you look at it and say there's no chance this is going to work? On the other hand, we'll talk a little about risks of duroplasty. And so there are times where even if I think the anatomy is not good for bone only, if I think they have significant additional risk to opening the dura, then it may be something where you don't. So for duroplasty, bad for bone only, no significant additional risk, or maybe you did a bone only and it didn't work. For patients that were kind of on the fence or they're not sure which they prefer, we'll usually do intraop ultrasound to kind of get a sense of what it looks like. This isn't the best picture, but I think it highlights some of the things I like to think about. So what's good bony anatomy for a bone-only decompression? When the tonsils are indented by C1, or the area of C1 is really tight, that is something where you can think, okay, if I get rid of the bone there, will that help? This one shows a little bit of it where it's a flat skull base. And I think this is more likely to indent things when the skull is flat there than if the skull base were coming down here, because it's more likely to cause a direct pressure. This, I think, is a good example of an indent at C1. So this patient is a toddler who had tussive headaches, and we can see right here, C1, the tonsils are kind of coming over it. It's kind of there's plenty of space below, but right at the area where C1 is, it's tight. So I thought this was a good case for a bone only. That's what we did. Here's the post-operative imaging, and the patient symptoms went away, and he's done very well. And so this is when you can look at and say, I don't think I need to open the dura in this case. What about the additional risks? So I think young age, especially in the pediatric group, babies can have a sinus running in the dura, which has a high risk of bleeding during surgery, and obviously a very young child has less of a blood volume, so that can carry a higher risk. In the adult patients, I tend to think more about connective tissue disorders or patients that have significant obesity. So one example here is a 2-month-old who presented with stridor. When she came to clinic, you could hear her from across the hall before coming in, so it was clearly something that was symptomatic. So she was from out of state, so we arranged for her to get an MRI under anesthesia before we did the surgery to get a better picture. And we can see she has tonsils going way down to about, probably to C3. That being said, I think the issue is that at her age, I was concerned about bleeding. We also noted that her ventricles were bigger, so we did place a drain, which we were ultimately able to remove. But so we did a bone-only decompression. Here's the immediate post-op scan where you can just see where we removed the bone. Obviously, it doesn't look much better at all because it's going to take some time for the dura to come out. But if we kind of look over time, here's a scan pre-op, one 2 years later, and then another one 6 years later. She's developing normally. Her stridor has gone away. And surprisingly, even to me, she hasn't required additional surgery at this point. Usually, I tend to think the kids under a year of age will probably have to redo. Now, she's still growing, so potentially not out of the woods. But the other thing you can notice is that over time, the anatomy actually gets better. So it is something that to think about. And so she's better. Was it worth the additional risk that we might have put her through? Here's a patient that I took care of with tussive headaches and a diagnosis of Ehlers-Danlos syndrome. So clearly it looks like she has a symptomatic Chiari. She had a decompression done somewhere else and came to see me for a second opinion a couple of months post-op with this scan. So she has a very large pseudomeningocele. Ultimately, we were able to treat it by going back in and also placed a drain. I did a ventricular drain to help take pressure off, and we got it to heal. But the question is, was it worth the additional? And so in general, my practice, if someone has a bad connective tissue disorder, I tend to think about starting with a bone-only decompression, even if the anatomy it looks like one that may not work. And here's an example of this. This is a teenager with severe EDS, multiple surgeries in different parts of her body, and significant tussive headaches. Here's her MRI scan. We can see the tonsils going down to the bottom of C1. We had a lengthy discussion about it and did the bone-only decompression. Anatomy gets better. It's not perfect. Symptoms get better. Not completely gone, but her quality of life is much improved. She can do the things she wants to, and she can tolerate the headaches that she had. Interestingly, she came back to see me about 3 years later, and look at the imaging. It had actually gotten significantly better. I don't know that with a duroplasty that I actually would have gotten a better result in the long term. Now, it did take time to get there, but it's something where it's not clear that the additional risk would have been justified in her. Now, there was a point in her history where she came back and we were discussing going back and whether or not we would take the additional risk because she had a period where symptoms were a little bit worse. And we didn't do it, and it worked out. But I think if you don't, you just have to think about it and keep it in your mind that it's an option to do in the future, but I'm going to take less risk up front. Another example, an adult female with obesity, Chiari, and syrinx. She presented with thoracic pain, had a decompression at another hospital, came here with headache, blurry vision, and a collection in her neck. And you can see this massive pseudomeningocele here. And with the blurry vision, I was worried about increased intracranial pressure. Turns out she had papilledema. So it took actually multiple surgeries between putting a ventricular drain, attempting to close this off, and then ultimately she had a shunt, and which fixed the problem. But it's another one of those things where if you're not, I wonder if in this patient whether hydrocephalus was the primary problem, we couldn't have avoided it, but B, in someone with all these comorbidities, are you better off with a lesser procedure to start with? Here's a patient I saw after that, also with tussive headaches, multiple comorbidities, and an elevated body mass index. We had this same discussion and did a bone-only decompression. Again, symptoms improve, not absent, but her quality of life is better, and she's happy without having to take those additional risks. So those are patients where I think about doing bone-only based on characteristics. What about the bad for bone-only? I think retroflexed odontoid. So where the skull base anatomy is pushing from the front, so you don't have as much room, so you want to make as much room as possible. This is a patient who came to me that had a bone-only decompression done somewhere else and said that the headaches never got better. And so this is someone that with this anatomy, I would think that up front, my recommendation would probably be to open the dura. Again, this is my recommendation. There are a lot of people who say, I just start with a bone only in everyone because it's less risk. There are other people who do a duroplasty in everyone. And I think it really is, you have to find what you feel comfortable with. This is the post-op on this patient after we opened the dura and shrank the tonsils, and obviously it's much better. And it's just something where I think up front, this is a patient where I would say, you know, if you really want to avoid the risk, we can try it. But I think there's a high risk it's not going to work and you're going to need an additional procedure. So my take for bone only versus duroplasty is it really goes back to patient selection. Bone only is more likely to work in some patients than others, but I think if you're concerned about elevated risk, whether significant obesity, elevated ICP, connective tissue disorders, your risk-benefit discussion may err on the side of taking less risk up front. I think another thing is we have to think about our failures. I think it's very easy to include talks about patients who came from other places, but obviously we all have our own failures. And I think it's important to think about why we made the wrong decision. So if I did a bone only, why did they need another procedure? One thing, and as I admit to all my patients, is I'm really bad at predicting scar. So something where maybe we do a bone only, and it looks good when we look with the ultrasound. And actually at their first 1 month visit, they're like, I'm doing great. My symptoms are better. I can laugh without getting a headache. I can sneeze. I can yell at my kids' sporting events and not get a headache. But then maybe 3 months later or 4 months later, the headaches come back. And when you get an MRI at that point, you just see a scar ball like where C1 was. And that's something that at this point, I don't know that I have a good ability to predict. So I talk to people about that. Missing an underlying diagnosis. So, I talked before about high pressure, low pressure. I have one patient I can think of where I missed low pressure, and we did the procedure, and he got better, but then had some headaches probably related to low pressure. And so I think it's something where we just have to think about why it doesn't work and are we missing something. And I think we just have to be objective and think about that. I think an important thing, too, is the distinction between being decompressed and having a good decompression. So I have a patient that I saw with a complex history that had a bone-only decompression years before somewhere else, who had a clear improvement in symptoms, but came back worsening recently. She saw the person who did the decompression, who said that there was a good decompression on the imaging. And if you look at the pre-op and post-op, there is a good bony decompression, but the issue is the foramen magnum's still full. So you can still have a symptomatic Chiari despite that big bony decompression. So it's really looking at, what's going on in this area and does it need more space? And so I think that's another thing we have to think about is you may have done a technically perfect decompression, but if the patient still has fullness there, they can still have symptoms, and what else can we do to fix it? So again, going back to this slide, the right operation for the right patient. What about tonsillar reduction, stent placement? These two come together a little bit. And I think when we treat a syrinx, I like to think about the importance of spinal fluid flow. Now, one thing, getting back to the guidelines, the importance of spinal fluid flow is not the same thing as the importance of cine flow studies. Spinal fluid flow is what's actually going on in your body and what it may be contributing, whereas the flow studies are something that we can use as an adjunct, but it's not clear to me, at least with the way the studies are done, how helpful they are. For instance, I have a number of asymptomatic patients who have abnormal flow on a flow study. So just having abnormal flow doesn't tell me anything. But what I think about is if somebody has a syrinx, I have to restore normal flow on an anatomical level, not necessarily what we're seeing on that scan. And so here's a patient example. This is a teenager with pain and numbness long-standing. Effectively, you can't see his spinal cord because it looks like it's all syrinx. He's someone that he was just tight, and so the spinal fluid couldn't get out. We did a decompression with duroplasty. There's now space. We didn't have to do anything else. You can see the syrinx got dramatically better. You can actually see his spinal cord now. Here's another patient, teenage female with numbness and headache, had a surgery. Here's the initial pre-op scan with this syrinx. Here's the post-op scan a year later. You can see that there is a decompression here, but it's still tight right here. So the flow is probably impacted. It's a year later, based on our guidelines. We actually, Class B have a grade B recommendation. I felt it was time that we should try something else. That being said, I thought, we just needed to open this up. Here's an intraop photo. And if you can't tell what you're looking at, it's because I couldn't either. And it's because there's all this scar here. The tonsils are scarred together. And so it just took a while to take this scar down. And then we can see at the end, I'm separating between the tonsils. We have a good spinal fluid outflow. There's no block there. And here's what the two tonsils look like with taking all of that scar down. And then if we look at the scans, here's 3 months post her redo, the syrinx got better. So the fact is that she didn't need a stent or she didn't need anything else. She just needed the foramen magnum to be opened. Now, contrast that with this patient, who is a patient with an incidentally found syrinx, getting scanned for other reasons. After some time, this was treated by one of my partners and ultimately decided to do a decompression. Here's 1 year follow-up. Decompression looks good. Syrinx is pretty much gone. I met her about 3 years later. We can see the syrinx is starting to come back. She's asymptomatic, so they wanted to watch. We did for some time. 5 years post-op, fourth ventricle is getting bigger, syrinx is getting bigger. We decide that it's probably time to go back. Here's what we find in the operating room. Thickened, scarred arachnoid. We can see the tonsils separated here. Opening up between, this is where the outflow should be, and there's a membrane there. So I opened up that membrane, but my concern is I couldn't make it any bigger because of vessels around. So my concern is that this is just going to close down again. So this is a patient that I think is a good example of who would benefit from a stent. So it's actually a shunt catheter, which you can actually see here on the ultrasound. This is the fourth ventricle, the trigone there. The tip of the stent is sitting right above that, and then the tube comes down, it comes out, and then it drains the fluid, keeping that hole open to the cervical subarachnoid space. She had a scan 11 days post-op for other reasons, but you can see even 11 days later, the syrinx is dramatically better. We can see the stent kind of sitting in position there. So I think for a syrinx, you have to, again, going back to the idea, you have to fix the underlying problem. And I think it's CSF flow. But sometimes it's just there's not enough space and you have to make enough space. Sometimes it's actually that there's something blocking the flow and you have to fix that. And that's where I think a stent can be helpful. What about tonsillar reduction? So shrinking the tonsils. And you can shrink them with cauterization or you can actually remove tonsils. And some people do that. In general, in my practice, my goal is that the tonsils are within the decompression. And so if I can't see the bottom of the tonsils after I open the dura, rather than removing C2, which in my personal opinion is something that is probably more likely to increase risk of instability long term, I'd rather shrink the tonsils up. And so that's something that I do fairly regularly. And what I've said to my patients recently is what's interesting is I always think about it as I like to do what that patient needs. And historically, I used to shrink the tonsils a lot less, but that's because I was opening everyone's dura. Now I open less dura, and I think the patients who I wasn't shrinking the tonsils before are probably the patients that are now getting bone-only decompressions. So I feel like in my practice, the percentage of patients whose dura I shrink when I open the dura tonsils I shrink after I open the dura has gone way up. Because I think a lot of the patients who I wouldn't have done it are now not having their dura opened. And so here's a patient that's kind of a good example of tonsillar reduction. This kid presented with a chronic cough and bad sleep apnea. And you can even see here on the scan, it's hard to make out where the tonsils end and where the spinal cord is. So we brought him to the OR. Here's the ultrasound. And I think this is a good example of an ultrasound where bone only probably would not work. You can see here the tonsils kind of pulsing. There's no room between the dura and the tonsils. So if you just stop here, I would say it's probably not going to work. So this is the intraop photo. We can see here's the bottom of our dural opening here, and we just see tonsil going all the way down. We don't actually see an opening. And so this is someone that I would historically shrink the tonsils on, and that's what we did. One point I like to make is I don't cauterize the medial aspect of the tonsils because I worry about scarring and the two sticking together. So you can see this is all, this white is where we cauterized, but you can also see now that the tonsils are fully up in the opening. So, you know, thought we didn't cauterize this side as much because of the vessels. And so I went and spoke to the family after and said we should kind of cauterize tonsils as much as I felt we could, but we'll see. So his cough got better, but his next sleep study, his central apnea had actually gotten worse. You can actually make out now, I think this is where the tonsils end and the brainstem / spinal cord begin, but we decided we needed to go back. Here's the ultrasound now. It looks a little bit better than it did the time before, but still not good. And so here is actually intraop, watching, and you can see the tonsils kind of pulsing and covering this fourth outflow and going all the way down. So this is a patient where I don't do it frequently, but I actually did resect tonsil. And so you can see there's a small hole here. I tend to, when I resect tonsil, I tend to do it internally, so you're not causing a large opening for scarring. And you can see this is, again, the fourth outflow, how much higher that is. And then here's the ultrasound after that, and you can see now there's a nice spinal fluid space. And as you would expect, he got better. So he was weaned off BiPAP within a short period of time. Scan looks much better. He's now a couple of years out and doing very well. So again, going back to the questions, what's the goal of treating patients with Chiari? And it's the right operation for the right patient. Do you operate? Do you open the dura? Do you shrink the tonsils? Do you place a stent? Do you fuse? I'll defer to other people. But I think, nowadays we talk a lot about personalized medicine and using genomics and all of these things. And I think Chiari is one of those things where no two patients are alike. And so it's really the right decompression for the right patient. Do you need a decompression at all? And so trying to give the best advice and doing the best surgery for each individual patient. Even within what I recommend, different patients may have their own risk-reward profile. And I'll have some patients who are like, I don't want to do anything more than what I need to. If I have to do another surgery, I will. I want to do the least upfront. I have other patients who are like, I don't want to come back, do everything, be aggressive. And so I think even for those patients, the right surgery may be slightly different, because maybe we don't get them fully better, but maybe it's good enough for what they want for the amount of risk. And it really is thinking about the upfront risk of surgery versus the risk of additional surgery later on. I think for failures, we really have to make sure we're not missing something. Like, do they have low pressure? Do they have high pressure? Do they have something else going on? Do they have a connective tissue disorder? And that's why they have a CSF leak. And I really think this is something that having more data with more individuals will help us with these answers. So the current problem is that the literature doesn't give us true guidelines for taking care of these patients. There is discussion of what's called practice parameter to replace the guidelines. But really, at the end of the day, we need new literature. And so how do we get there? We need prospective data. We can't really draw good conclusions based on a single surgeon's experience or case series. We really want to look at multiple surgeons from multiple institutions because we all do things differently. And there's so many variables that the more data points we have, the more we can think about that. So one thing is, as was alluded to earlier, the Chiari Surgical Success Scale, which we're a part of. And the aim here is to develop a scale that helps predict favorable response to surgery. And we can look at other things too, including patient-centered outcomes, complications, imaging, to try to get additional data for that. The benefit of that is we have that information, but there's still going to be some stuff missing. So here we have our Clinical Research Center. Again, fortunate for the donation from Dr. Wild. And I think we're really taking kind of a three-prong approach to it. One, the benefit of a place like Hopkins is there's a large number of us who do this surgery, and we all have our own practices. So just looking back over a number of years and seeing what data do we have and what can we use in our own variability to answer some questions, but also to shine light on what questions should we be asking. So we have a retrospective database that we're still working on filling in all the data points. We're part of the CSSS, but again, that's only surgical patients. So that'll help with the patients that we're really thinking about surgery. But what about all the patients that we're following over time? What about the one who isn't getting surgery and what happens to them? So we're including all patients with Chiari, whether or not they're having surgery. Benefits of that: one, a patient population that can serve as controls for all the surgical patients, but also giving us natural history data. There was the one question about treating asymptomatic patients. And I think there's good evidence that there's not, but that we don't need to. But it's nice to have these people to follow over time where you're doing it prospectively to say that. And also with all these other diagnoses that we're seeing in patients with Chiari, and is it that it's more common with Chiari, or is it just that they're more common to present for medical care and be diagnosed with Chiari because they have EDS or POTS or these other things? But what happens when we're treating the other parts of that and what gets better? And I think having that data will be helpful. So at the end of the day, what I would say is Chiari is a complex problem to treat because of all the variability and all of the other factors that are going on. The guidelines provide a framework of what we know and what we don't, but what we know is that there's a lot more work to be done. So we need to collect data as much as possible to best treat or not treat each patient. And so as a patient, how can you play a role? The biggest thing you can do is, if you have a Chiari, is to participate in research. Typically, it has to be done through clinical care, so it has to be you have to be a patient at the center doing the research. I will give a quick shout out to my colleagues doing genetic studies at WashU and MGH, who you can contact them directly and not be a patient there, and they'll send you kits and you can do genetic testing with them. So those are the exception, but otherwise, following you and seeing how you progress either with treatment or not treatment has to be at a site that is asking these questions. And I would say, especially for surgical patients, if you want to be involved in CSSS, you can contact Bobby Jones to find participating sites near you. If you're in Baltimore or want to travel to Baltimore, we're happy to take care of you here as well. And with that, I will open it up to any questions.